Another approach that we've done and that we could maybe discuss as well is the combination BTK inhibitor with venetoclax. So our experience then in the frontline setting has been encouraging. You've seen the data where the vast majority of patients after 2 years of treatment achieve a deep remission and are able to come off treatment. The follow-up is short, so therefore we can't really say, is this maybe the way to go for a certain subgroup of patients? It's treatment which has been well tolerated. It was geared towards either high-risk patients or elderly patients. But yeah, what argues for that approach is that the majority of patients achieve MRD negative remissions, can come off treatment. The counter argument you could make is, well, it's a bit more intensive regimen. You get more myelosuppression by combining those two agents. It's very expensive, obviously, because you combine two targeted agents for almost 2 years. But then on the other hand, you can stop the treatment. And I think it could be successful if in 5 or 10 years we learn that some of these patients maybe not relapse and maybe functionally cured. So I think that's the promise of this approach. On the other hand, I don't think it's ready for prime time until we really have maybe 5 years of follow-up. How would you think about those data?
Yeah, I mean, I think that, I mean, you've hit on all the salient points. I mean, I think one, the notion of getting patients off of therapy avoids all the cumulative toxicities that you might expect with some of these agents. And so being able to get them off, I think, is attractive from that standpoint. It is expensive. It's very expensive. But if you think about it, if you're giving them a relatively short amount of treatment, then instead of with 2 agents or 3 agents, instead of keeping them on it for indefinitely, maybe in the big picture, it's not more expensive, and you might save some of the issues with adverse events. And so I think, you know, I think all that research is really exciting and something that needs to continue. We talked a little bit earlier about, you know, combining with different agents. You mentioned CD20 targeted antibodies, and of course, I think this is also very controversial, right? I mean, we know from a series of studies you first presented a number of years ago that combining with ibrutinib with rituximab maybe accelerated the curve a little bit, but really didn't seem to change things. The progression-free survival and things like that really seemed like it was unchanged. More recently, we've seen, well, we saw the data from iLLUMINATE, which was a combination of ibrutinib with obinutuzumab, so a different CD20 antibody, one geared for more ADCC. That was a trial that wasn't comparing it. It was comparing to obinutuzumab with chlorambucil, and so don't have direct evidence, but there's a suggestion that maybe it's better. But hard to convince a lot of people that that's better. And then there's also the more recent ELEVATE-TN trial where acalabrutinib was combined with obinutuzumab, and that there's clear randomized data. There's a difference in progression-free survival that by adding the antibody to acalabrutinib, that you improve progression-free survival compared to the BTK inhibitor alone. And so a lot to think about there. You know, the pros and cons, and I'll get your take on this in a second. But maybe that it matters not only what the antibody is. Not all CD20 antibodies are the same. And maybe it matters what the BTK inhibitor is. Not all BTK inhibitors are alone. Of course, there's probably less problems with decreasing efficacy of acalabrutinib on ADCC, whereas we think with ibrutinib maybe that it does play a little bit of a role there, and maybe that's the explanation for the differences with that. But a lot of A lot of data. Some people think, well, it doesn't really make any difference because you're not improving survival, so maybe we're splitting hairs there, and it really doesn't make any difference. So, in your practice, outside of a trial, what's your approach?
I think CD20 antibodies, we are just so used to using CD20 antibodies. They have been so beneficial to so many patients. When we think about 10 years ago when we used chemoimmunotherapy, adding CD20 antibodies had such a profound effect on getting so many more patients into CRs and prolonging survival, PFS, and even overall survival when we think about the FCR data. So we are so used to using CD20 antibodies, and now the notion that CD20 antibodies are not adding so much benefit when you think about BTK inhibitors, at first glance, I think that might be a bit disappointing. And I would say at this stage, when we use BTK inhibitors, outside of clinical trials, there's not very solid evidence to say we need to add a CD20 antibody. But I think where CD20 antibodies could come back into the play when we talk about BTK inhibitors is when we talk about limited duration treatment. Maybe they can just be a way to get patients into deeper remissions faster. I think that's pretty clear from all the data. If you add rituximab, if you add obinutuzumab to a BTK inhibitor, patients will be in a remission faster. And then if you like the idea of treating patients not for years, but maybe for a shorter period of time, then a CD20 antibody could be a good addition. And that way, we might still see like a renaissance of CD20 antibodies when it comes to BTK inhibitors. For venetoclax, I think the evidence is pretty clear that the addition of CD20 antibodies with venetoclax deepens remissions, and that has an effect on PFS, because we're talking about limited duration treatment anyway. And I'm kind of thinking, or that's my reading of the data, is, well, maybe with the BTK inhibitors, if we had thought about limited duration treatment earlier, we would maybe have data that looked kind of similar to what we are seeing with venetoclax, where you see a benefit, where you see that more clearly if you talk about a limited duration treatment. So I think from a practical standpoint, as long as most patients still get long-term treatment with BTK inhibitors, the CD20 antibodies, their addition to a BTK inhibitor outside of a clinical trial, probably not necessary for most patients, unless you want to get a patient into remission faster, you want to debulk them with a CD20 antibody. But they may come back. I think they will come back if we talk about limited duration treatment. And with venetoclax, I think the data are solid that they should be added usually.
So the renaissance is really would be with a 3-drug regimen, combining all 3, where you're getting the added benefit, if I understand you correctly.